Hey everyone, welcome to the Next Year Amigos podcast. We have paper of the month. We have a unique paper of the month, our first non-GU paper. Yelena Janjigian from Memorial is with us to talk about some immunochemotherapy data, at least two separate trials in gastric cancer. So Yelena, welcome. Why don't you introduce yourself briefly and then maybe start with talking about, immune therapy in gastric cancer broadly, what was known before the study, which will be unfamiliar to most of our audience.
Sure. Thanks, Brian and Tom, for having me. It's an honor. I'm a medical oncologist and chief of GI oncology service at Memorial Sloan Kettering Cancer Center in New York. For the past several years, I've been focusing on trying to bring immunotherapy to our patients. In probably sometime, in 2015 or so, maybe even earlier, we saw initial data to support that, clinical use of pembrolizumab in treatment refractory in third line setting in gastric cancer. And also, so this was a single arm phase 2 study demonstrating survival benefit in the low teens, so like 14% in patients, rather response rate without a clear comparator arm. So it was based on historical control. So the FDA approved pembrolizumab in later lines after chemotherapy failure based on just promising response and promising survival. And simultaneously in Asia, nivolumab was approved also in pretreatment, heavily pretreated patient population based on survival benefit, but against placebo. So in later lines, so that was a traction 4 study. So we knew that once chemotherapy stops working and there's really nothing other than really homeopathic remedies, immunotherapy improved outcome in selected patient population. We have MSI, we have EBV, patients that are sensitive, high PD-L1 overexpressing tumors. In gastric, we use combined positivity score, which takes stroma and the tumor component. Mostly it's the stroma component. TPS is not a predictor. So that was then. And then, a few years later, the first study read out, KEYNOTE-62, which was in a head-to-head comparison in biomarkers selected using CPS1 as a cutoff, which is a very low selection. Most patients, I would say 80% of gastric tumors are CPS1 or higher. And using that cutoff, KEYNOTE-62 failed to demonstrate in first-line setting, sort of similar to what I think what you guys experienced in GU, that immunotherapy compared to chemotherapy did not improve survival. In fact, what happens repeatedly in GI tumors, even in MSI tumors, for the first 6, sometimes 9, sometimes 12 months, depending on the study, the curves always cross in favor of chemotherapy. And then later, there's a nice plateau on the survival curve, but it's a little too late for the immunotherapy arm, and the hazard ratio typically is not significant for outcome. So KEYNOTE-62 failed to demonstrate benefit, chemo versus immunotherapy, and chemotherapy won out. In fact, in that subset, this was a smaller study, splitting alpha over 5, different hypotheses. So they did have a chemo IO arm, and that didn't look good either. And I think there was trial design and sample size, et cetera. But KEYNOTE-62 completely, was a negative study, essentially.
That sounds like one of Tom's trials, like splitting
I was going to say, this is a summary of my career.
I know. Luckily, I didn't run that study. Luckily, my name was not anywhere near it because I think I was too,
I'd have been close to the front of that trial. I probably.
I was too focused on our small investigator-initiated studies, and sometimes that kind of detract. You can't open all the large studies, but. What I liked about CheckMate 649, first of all, they let me write it. And then also they let us include adenocarcinoma patients, both esophagus, G junction, and stomach. In other words, we made it a very clinically sort of intuitive and organic enrollment, as opposed to making artificial distinctions between, which 3 centimeters of the GI tract you happen to be in, which historically tumors patients, have been tortured over. So we excluded squames, we only included adenos, and I think it was a large study, but it was based on CheckMate 32, which was also in JCO, that looked at higher doses of IPI, so Nivo 1 IPI 3 versus Nivo 3 IPI 1, and it looked like the higher dose of IPI was needed in gastric. And in later lines, also kind of giving you a sense for what the data looked like, we had a 26% overall response rate, which
So
looked
Yelena,
like,
can I interrupt you for a second?
Yeah.
So essentially what you got then is you got in second line, you've got a CTLA-4 signal that you're comfortable with.
yeah.
You've got marginal activity for single agent therapy, and you haven't nailed the biomarker. So it sounds very similar to bladder cancer in that respect.
Exactly.
The big trial, which you published in Nature, and that big trial was CTLA-4 ipi-nivo, ipi-3 nivo 1 versus chemotherapy nivo.
No, that one. So we selected IP3. So we did Nivo 1 IP3 in the Checkmate 649 because that looked better in Checkmate 32.
We've done exactly the same in bladder cancer. We've got 901 doing exactly the same question. And so what were the results of that randomized phase 3 that you just put in Nature?
So the Nature was a 2-year follow-up survival. Basically, the initial paper was published in Lancet last year, which led to the FDA approval of FOLFOX nivolumab in all comers. So Checkmate 649 was a large study that enrolled all patients, and then the primary endpoint is in CPS 5 or greater. And both the primary endpoint and all intent to treat population, there was a positive signal. It's a dose response relationship. So as you would expect, the higher the CPS score, the better, the lower the hazard ratio. So for CPS 10 or greater, like the hazard ratio is closer to 0.66 or something like that. And then for all comers, the hazard ratio is like 0.8, right? But the large majority of all comers are CPS 5 or greater because that's 60% of the population.
And just to clarify,
yeah,
the Nature paper is 2 separate trials. One was chemo plus minus. Oh, it's one trial.
One trial
with 2 arms.
Follow-up of Checkmate 649, including the Nivo IPI arm.
I see.
Yeah.
Okay.
And the ipi-nivo arm was the new piece. The old piece was the chemo combination with nivo. That's positive and is now a standard of care. And what you were essentially presenting in this paper was the ipi-3 nivo 1 data, which we haven't seen before.
That's right.
And what did that show?
It showed, unfortunately, that, again, if you do well on Nivo IPI, you have a possible chance of cure. I mean, we have long-term survivors, even after 2 years, but it's not good enough to beat chemo in most patients. And the survival curves cross in favor of chemo for the first pretty much up to a year. If you do respond, your duration of response is doubled. It showed that in MSI patients, the response is pretty awesome, is 70%. And again, some patients with MSI tumors, which now we test upfront for early stage and stage 4 disease, less of a thing in GU, certainly not in prostate, but in bladder, it's a biomarker. But Nivo IPI was not good enough, and I think part of the reason why is because, again, we don't have a great biomarker. PD-L1, even using CPS or TPS, was not a clear-cut biomarker. MSI was useful, but it's only 3% of the population, and chemo works in this disease. And gastric cancer, although is sort of a relatively warm-ish tumor, it's just not hot enough for it to shrink fast enough with immunotherapy. These patients are sick; they just die of their disease if you don't induce response.
Yelena, am I right? Go ahead, Tom.
It's a couple of questions for the bladder cancer community. Number one, we've got the 901 trial. It's very similar. Chemotherapy is quite good at getting control of disease. Bladder cancer has a high TMB and a high T effector signature, but we know single agent immunotherapy is not great at getting in control of the disease. We're not sure CTLA-4 is going to make that big difference. And so we have this kind of fear that we may be reproducing this, although we have had a really good tail on the curve.
Yeah.
My first question is ipi-3 nivo 1 an easy regime to give to people who maybe are in their 7th or 8th decade of life with comorbidities, as is the case with urothelial cancer?
You know the answer to that. Absolutely not. It's not easy. It's not an easy regimen to give. And in fact, the study was, that arm, we closed it early because there were early deaths, and some of it was from toxicity, some of it was for progression. But ipi-3 is not it's not for a person, for a regular person, who's like in the community, may not have the backup of a tertiary cancer center behind them. It's not an easy regimen.
My second question, I'm going to hand over to Brian, is that we are kind of convinced ourselves that the TC biomarker, not the stromal biomarker, but the tumor cell staining in urothelial cancer may be more predictive than prognostic. And therefore, in PD-L1 expression in TC high patients, we feel we're going to get over the line because we're going to be leaving behind some of those individuals who do less well with immune therapy. Did you have the same hypothesis in your trial, and was it proven to be the case?
So tumor expression is not a useful biomarker in our disease. I think that some of it because maybe low percent of patients have tumor expression of PD-L1, but in several immunotherapy monotherapy trials in Asia, it was not a predictive biomarker at all.
Brian, I've got to ask the question. I'm really sorry. Then I will stop.
Oh, for crying out loud! Go ahead.
Look, I'm really sorry. I've got to ask this question. Was there ever a time that you felt the biomarker was really good in gastric cancer? And has that ship gone in the other direction? Or have you always been skeptical? Because in urothelial cancer, there was a time when we had biomarker labels and we were convinced the biomarker was going to work. And many people say we look back on that and we made a mistake. Are you in that same boat where you've been disappointed?
You mean PD-L1 specifically?
Yeah, PD-L1 specific.
Okay.
Yes,
So. Yeah, I think the FDA and the rest of many different regulatory bodies, including the Japanese regulatory bodies, voted to say that PD-L1 is not a reliable enough biomarker because EU is the only sort of major regulatory body that decided to restrict by PD-L1. And NCCN as well, I guess. But the FDA, many different countries in the world, decided that because it's such a continuum of response and it's not black and white, and also PD-L1 in gastric cancer is not a reliable biomarker. You can test the same sample multiple times and even show the same test to multiple pathologists, and the CPS score will change. So I think in clinical trials we got to continue to test and perhaps understand where it falls, but realistically in clinical practice, it's hard to use it.
We in Europe don't get everything right. The Napoleonic Wars are a good example of that. Brian, over to you.
Thanks for that.
I love my European colleagues and have nothing against them.
There's usually a European history lesson in these podcasts, Yelena. You may not be familiar. It usually goes over my head, so don't feel lost. I was going to ask about sort of tail of the curve, right? So for ipi-nivo or immune therapy in general, obviously one of the allures is tail of the curve. In renal, I think the role of ipi, it's sort of give it early or else it's hard to give late. It's toxic, probably doesn't salvage people. I think that's probably true. But if I look at the paper, to me, it looks like the tail of the curves for nivo chemo and ipi-nivo are pretty similar. If anything, the nivo chemo curves look higher. So I guess the question is really, do you think, what's the role of ipi in that tail of the curve? It doesn't sound like it's going to be developed further, but just curious.
No, I think it'll be hard to develop it. I think if I was to write Checkmate 649 now, we wrote it, and got it, like many years ago, but if I were to write it now, I wonder if we would have tried to combine low-dose ipi with FOLFOX nivo and see if that, because I do think, I agree with the renal cell guys that giving it early is probably, and I've had enough people in clinic who I treated in later lines who I've changed their lives with dual combination, even in PD-L1 relatively low expressing tumors, that there's definitely something there, but it's not going to be a strategy for large follow-up studies, particularly since now the field is moving toward dual tumor and anti-PD-1 checkpoint inhibition. Our data with TRAS Pembro, for example, in HER2 positive disease, the responses here in Checkmate 649 with chemo IO, the improvement in overall response rate is 15%. We saw 23% improvement with dual tumor and checkpoint inhibition with zero additive toxicity, right? So you're not even hurting patients.
And so do you think anybody will investigate ipi further, be it low dose, be it in biomarkers selected, or is that sort of asked and answered? you think the field's moved on, like you say, to other targets, if you will?
I think in squam, right? In squam, it may checkmate 648 demonstrate benefit. And that was in New England Journal of Medicine. Oops. Now, yeah.
I'm not sure what's going on.
You missed the joke. It was good. Right. So, because like even in squam, where nivo, it's a lower dose of ipi, nivo 240 and an ipi 1. Where like the survival is positive against chemotherapy alone, not chemo IO. The concern is in GI is that these patients, you can lose them. They can drop off, and their survival is really in the first 6 to 9 months is negatively impacted in all. And so it's tricky. You're like playing chicken with this disease. Is it going to take off and you're going to lose the patient, or are they going to respond?
Yelena, I've got one more question before we stop. In kidney cancer, Brian spent a lot of time looking at RNA signatures with mixed results. I'm not sure we're making huge progress there. In bladder cancer, we've struggled with PD-L1. We're now looking at TMB and ctDNA. We also like T effector signatures, but we haven't really nailed the second generation of biomarkers yet. How are you getting on with second generation biomarkers in gastric cancer to predict response to immune checkpoint inhibitors?
Yeah, I think it's a great question. Same basically situation. These RNA signatures, I mean, the problem is a lot of DNA is so stable and it's easier to study. All of these other, next generation biomarkers are just haven't been reliably useful, and they're harder to do in uniform patient population. And also now, since IO is available in all comers, it's going to, you can't randomize a patient to non-IO containing arm anymore. So that ship has sailed. I would say it would be helpful to go backwards and try to figure out a biomarker for chemotherapy resistance. And if you know that someone is not going to respond to chemotherapy, then try IO in those patients first. Because, right, I think chemotherapy and this platinum signatures, I know in bladder, I mean, I talk to Dave Solid all the time, and we were trying to figure out what are these signatures of platinum sensitivity, and in gastric, all of these newer, even germline analyses and so on, have not shed light. But I would say that would be a helpful next step for us.
And maybe last question from me, in RCC, we're trying to figure out the role of sequential immune therapy. Do you just get one shot up front, and then if you don't respond, can you give, salvage immune therapy, be it CTLA-4 inhibition or something else? Is that being tested in gastric cancer? So chemo nivo up front sounds like standard of care.
Yeah, it is. And
looking at alternative checkpoint inhibition or something in the salvage setting.
Yeah, I mean, I think there's a lot of interest in it, and unfortunately, some of these combination strategies haven't panned out even in naive setting in second line. So in patients who were chemotherapy exposed but not IO exposed, a lot of so far, the data with these combination antibodies have not been great. But we're trying. I think newer generation of ADCs, perhaps in combination with immunotherapy. Certainly CAR T cell therapy, but it's the next jump. I feel like checkmate 649 was the easy, obvious solution, and then, but it's like all good things obviously are easy, and then the next thing will take us another 10 years to figure out.
Last question from me. The biomarker piece that you put together looked at MSI high, and you had terrific results. Could you explain why MSI high is important in gastric cancer? We don't spend much time looking at it. And why MSI high patients would respond to immune checkpoint inhibition?
Yeah, that's my favorite topic. I think it's important in gastric cancer for two reasons. One is because in early stage disease, actually there's data to suggest you can hurt them with chemotherapy. So I've had numerous stories, and I just spoke to a colleague at a community center who experienced this. If you give early stage MSI gastric cancer chemotherapy, they may actually progress through treatment and then develop not resectable disease. So, and in stage 4 disease, and so these tumors inherently may be chemotherapy refractory, in gastric cancer in particular. And now using circulating tumor DNA and other MRD assays, we perhaps can select and rescue those patients who after primary resection still need something. And we have a MRD study, minimal residual disease study, to do that. For stage 4 disease, I mean, it's similar story to the initial Alexandrov paper and other. It's just they have a lot of neoantigens and things to target. We know that in gastric, outside of MSI patients, TMB is not a good predictor. So it's really about MSI. These are mostly non-Lynch patients, but in some cases it's Lynch too, so we always do genetic testing. I guess the big question is whether or not they need chemotherapy even, or if you can just do immunotherapy, or if in those patients we need dual anti-PD-1, anti-CTLA-4 blockade.
This has been terrific. There are so many differences between what we do in bladder cancer and what we're looking at, because we like TMB. It seems to always work. Now, we've never tested it properly. And it looks like we're going in different directions. I think we've oversimplified this by assuming we're going to show similar results in similar tumor types. Mm-hmm. And just because you've not been successful with IPI3, nivo1, I think 901's got a good chance of bladder cancer being positive still. Wouldn't it be interesting if that was the case?
And in bladder, you have HER2, so you should go after that with dual anti-HER2, anti-PD-1.
Yeah, well, I think Jonathan is doing that. I think we're doing
that. Oh. Somebody in your building. Yes. Yeah. Yelena, thanks. This has been great. I learned more about GI cancers in this 20 minutes than I did in 3 years of fellowship in the 20 years since.
Always happy to come back. Thanks again for having me.
Maybe we should start a GI cancer podcast series.
We should, but I don't know. I couldn't come up with anything better than your name. I mean, that's a pretty awesome
I think maybe name. Gastramigos. I don't know. We'll talk about it.
Gastramigos. Yes. Perfect.
All right. Thanks so much.
Bye-bye.
Thank you. Bye.